The characteristic polycystic ovarian syndrome occurs when a state of anovulation persists for a sufficient length of time. The typical textbook patient presents with absent or irregular menstrual cycles, obesity, or great difficulty in maintaining normal weight, and some degree of hirsutism or excess facial and body hair in a male pattern distribution. There is often a characteristic hormonal pattern, commonly referred to as a hormonal imbalance, and a typical ultrasonographic picture of the ovaries, consisting of enlarged ovaries with an increased number of follicles, often in a string of beads-like pattern. Nevertheless, insistence on these rigid criteria will exclude women who are anovulatory but are hormonally normal. Indeed, there are thin polycystics and anovulatory women without excess facial and body hair. Insulin resistance, which is a cause of glucose intolerance, is often seen in women with PCO, or polycystic ovarian syndrome. Insulin resistance, which is a cause of glucose intolerance, is often seen in women with PCO, more commonly in those who are obese and hirsute. It is these women who are at higher risk of developing diabetes and heart disease later in life. Treatment of these patients with insulin-sensitizing medication, such as metformin, along with weight loss, may help reduce the risk of long-term health consequences, and in addition, ovulation may occur and pregnancy can result. Women desiring pregnancy who do not conceive with this treatment may be offered other hormonal treatments, such as clomiphene citrate tablets or injectable gonadotropins. In vitro fertilization with blastocyst culture and transfer is often the safest means of getting sperm and egg together in PCO patients. Polycystic patients will have an exaggerated response to ovulation induction and produce an excess number of eggs. With IVF, we can control the number of embryos that are transferred back to the uterus and thus prevent what we call high-order multiples, which means a pregnancy with more fetuses than